All right, so good afternoon, and thank you for joining us here today. We have the pleasure of having Dr. Shannon Kay presenting from Adipokines to Airways, and this is particularly relevant for what we do in asthma. Dr. Kay is graduated from internal medicine at the University of Michigan, where she was also a chief resident before coming and joining us for our pulmonary fellowship here. Her work over the last few years has been focused on understanding the sex-specific differences in asthma, and as part of her research, she has also identified some specific overlaps between genomics of asthma and obesity, metabolic health, which is really important for kind of like some of the clinical presentations that we have in asthma. And we're really looking forward to hearing a little bit more about this. So yeah, welcome.
Thank you. Good afternoon, everyone. Welcome to Pulmonary Grand Rounds. And thank you to Dr. Mathe, who's joining us from Florida, for the opportunity to present today. And thank you, Jose, for the kind introduction. So today I'll be taking you all on a maybe fun and exciting, but at least hopefully informative journey from Adipokines to Airways. Along the way, my goal is to unravel what we know about metabolic inflammation in patients affected by both asthma and obesity. Here's the CME slide. It's also behind me and in the chat. So before we get started, I wanted to wish you all a happy belated World Asthma Day, which we observed yesterday on May 5th. And a happy National Asthma Awareness Month, which we honor throughout the whole month of May. Hopefully this is a timely opportunity to get us all thinking a little bit more about our patients with asthma. So on that note, I think it's important to start out with a case to remind ourselves why we do what we do. So this is a real patient that I met in my YCAD clinic just over 2 years ago in February of 2024. Her name is Miss AB, and at the time she was 33 years old. She came to YCAD for a fourth pulmonary opinion of severe asthma. And to review the timeline for her disease, she had no prior respiratory issues prior to a COVID infection in November 2020. She had typical COVID symptoms, but felt that she didn't fully recover to her baseline. In November 2021, she had her first respiratory exacerbation, and importantly, she was noted to have high peripheral eosinophils at that time. To treat her symptoms, she was started on an inhaler for the first time, as well as a course of prednisone. This happened again in December, requiring another steroid course. In February, she found out she was pregnant. Labs in March showed elevated eosinophils. She had another flare in April 2022, and given overall poor asthma control and frequent exacerbations, she was started on Nucala, or mepolizumab. In June 2022, she contracted COVID again and had a flare requiring steroids. She had a healthy baby girl in September, and then her asthma really started to ramp up. She subsequently had flares in October, then December in the setting of human metapneumovirus, then February, then March, this time she had rhino, then June, this was around the time of the Canada fires, and that's what she attributed that flare to. And then again in October. This prompted transition from Nucala to Tezspire. Then she was hospitalized in January, and then again in February. Thankfully, she didn't need the ICU, and she didn't need to be intubated, but these were the most severe exacerbations that she had had. And shortly after her hospitalization, she came to meet me in YCAD. So since her respiratory issues began, Miss AB has gained over 45 pounds. She did start with a BMI in the obese category, 38, but when I first met her, her BMI was over 45. Additionally, her A1C went from a normal range to pre-diabetic. So to summarize, in just the past 2 years, she's had 10 exacerbations requiring steroids, 2 hospitalizations. When I met her, she had been on high-dose oral corticosteroids continuously for the past 5 months. She was on 70 milligrams at the time I met her, and she had a lot of trouble weaning below 40. She had started a PPI for GERD. She started CPAP for sleep apnea. She was on chronic opioids to control the chest pain because she was coughing so much. She was on Lasix because she was swelling so much from the steroids. And she'd actually started insulin for steroid-induced hyperglycemia. She had previously worked as a CNA, but she'd been out of work on disability for a few months at that time. And now she even has trouble caring for her young daughter and needs her mom's help to do so. So seeing this patient raised a number of clinical questions for me, namely, does obesity increase the risk of developing asthma, and does it drive more severe disease? Is there a difference between males and females? What are the mechanisms linking obesity and asthma? Is this a distinct phenotype or even a distinct disease rather than just a comorbidity? Next, why do our standard therapies fail in these patients? Is obesity a treatable trait? Can weight loss meaningfully improve asthma outcomes? And finally, how should we optimally manage patients affected by both obesity and asthma? So I thought these are good questions to frame this talk for today. So we'll talk about epidemiology of asthma and obesity. Next, I'll present some of the mechanisms and how they affect our diagnostics. We'll talk about how obesity affects response to asthma therapies and how asthma responds to therapies targeting obesity. And finally, I'll propose some optimal management strategies for this group of patients. So before we talk mechanisms, I think it's first important to appreciate the scale of the obesity problem in the US and how obesity is not just a comorbidity in asthma, it's increasingly defining who develops asthma and how the disease behaves. So obesity and asthma prevalence have both increased over the past 3 to 4 decades. This is data depicting US national trends based on CDC surveillance and NHANES data to illustrate population-level patterns over time, and this is stratified by sex. So obesity prevalence increased substantially from 2000 to 2020. In 2000, the age-adjusted prevalence was about 30%, but by 2020, it had risen to about 40. And this isn't shown here, but morbid obesity also increased from about 5 to about 10% over the same period. Taking this further, nearly 1 in 2 adults is projected to be affected by obesity by the year 2030 here in the US. On the other hand, about 8 to 10% of adults are estimated to have asthma here. And this has only risen modestly over this time period. I'd also like to highlight that adult females have consistently higher prevalence of both asthma and obesity. Here's a map showing the bivariate distribution of adult obesity and asthma in the continental US. This is data from the 2022 CDC Behavioral Risk Factor Surveillance System. Darker purple colors indicate increased asthma prevalence, and darker teal colors represent increased obesity prevalence. And you can see that in the Midwest, Southeast, and Appalachian regions, there is a high clustering of both high obesity and high asthma prevalence. Generally, these areas also have higher poverty rates, limited specialty access, and are more likely to be rural. So this map illustrates that obesity and asthma don't simply coexist randomly across the US. Instead, they cluster geographically, supporting the idea that obesity-associated asthma represents a population-level issue. Here's a bar graph looking at asthma prevalence by BMI. Normal weight is defined as BMI less than 25, overweight 25 to 30, and obesity is greater than 30. Here I used NHANES data from the 2011 to 2014 period, and you can see the increasing prevalence of asthma with increasing BMI. This demonstrates a clear dose-response relationship. And here's that same data, this time stratified by sex. Asterisks indicates significant differences between females and males. And here you can see that the sex disparity widens with increasing BMI, and the largest is in adults with obesity. Next, I estimated sex stratified adjusted prevalence ratios. And here I found, again, a definite sex difference. Obesity was associated with a robust 65% higher asthma prevalence among obese women. There was an upward trend in overweight women, but this was not statistically significant. In contrast, the association in men was modest and not significant across BMI. So based on this data, the association between obesity and asthma appears substantially stronger in females than males, suggesting an effect modification by sex that really drives that increasing prevalence with BMI. So we often think about obesity-related comorbidities as things like diabetes, hypertension, and hyperlipidemia, but asthma is not usually top of mind. Given that, I wanted to take a step back and ask, is asthma actually common in patients with obesity at the population level? So here, again, is NHANES data. This is looking at comorbidity burden across increasing obesity severity. And if you look at the asthma row, what stands out is that prevalence increases steadily with BMI from about 16% up to about 30% in those with BMI over 50. Now, one important limitation here is that NHANES doesn't capture certain obesity-related comorbidities particularly well. Most notably, you'll see that OSA is missing from this list. So to better understand that piece of the puzzle, I looked at another data set. So this is data from all of us. So as expected, we see graded increase in risk across obesity class for nearly every condition. But importantly, asthma is still here among those comorbidities. And in class 3 obesity, asthma risk is more than doubled, with a hazard ratio just over 2. So asthma is not a rare association. It tracks with obesity severity in a way that looks similar to other classic cardiometabolic comorbidities. So I think this suggests that asthma does belong in this conversation. So that raises another question. Why are obesity and asthma coming together? So one reason is that they share many of the same upstream risk factors. First, air pollution. Things like particulate matter, nitrogen dioxide, tobacco exposure. These are obviously well-established risk factors for the development of asthma, but they are also separately linked to increased risk for obesity. Next, diet, nutrition, physical inactivity. These contribute to weight gain and also to reduced cardiopulmonary fitness. Increasingly, we're recognizing the role of the microbiome and how early life exposures can alter both metabolic and immune development in ways that predispose to both obesity and asthma. Finally, psychosocial stress and socioeconomic disadvantage shape all these exposures: environment, diet, access to care. And what's shown here is that these risk factors act across the lifespan, from early life into adulthood, continually reinforcing risks for both of these diseases. So obesity and asthma may be considered parallel consequences of a shared environmental and developmental pathway. So beyond shared risk factors, there's also evidence that obesity actually modifies how patients respond to exposures, particularly air pollution. So on the left, this is a 3D model. These are always tough to interpret, but we're looking at the interaction between BMI, particulate matter, and respiratory symptoms. And you can see that as BMI increases, respiratory symptom burden increases associated with increasing exposure to PM2.5. On the right, you see a similar pattern with nitrogen dioxide. In patients with obesity, increasing pollution is associated with a clear rise in asthma symptoms. So you can see that here with that dashed line. Whereas in normal weight individuals, that relationship is much flatter, and if anything, almost kind of downward. So obesity doesn't just coexist with asthma, it appears to amplify susceptibility to environmental triggers. So we have shared upstream drivers, then exaggerated downstream response. Another way this interaction shows up is in susceptibility to respiratory infections. So this study from Ann Dixon's group looks at adults with asthma and compares outcomes by obesity status. What you can see is that while the incidence of infections, upper and lower respiratory tract infections, is relatively similar, the severity is clearly higher in patients with obesity. They're significantly more likely to require systemic steroids and to have healthcare contact during these infections. And importantly, the pattern holds for both infection-specific events and also all-cause exacerbations. So with that in mind, it makes sense that obesity contributes to asthma-related morbidity at the population level. So this analysis links NHANES data with National Emergency Department visits to estimate how much asthma morbidity is actually attributed to obesity. And what you can see is that a substantial proportion of asthma ED visits are linked to obesity. In females, about 17% of ED visits are attributable to obesity, translating to about 1 in 6 asthma ED visits among females. In males, the number's lower, around 8%, but still meaningful. And this figure is now looking at asthma-related mortality rather than morbidity. So absolute numbers are much lower. So this shows sex-stratified trends in obesity attributable asthma mortality using CDC Wonder mortality data with population attributable fractions derived from NHANES and applied to national mortality rates. So 2 important things. First, obesity attributable asthma is consistently higher in females across the entire time period. And second, although the absolute numbers are small, as expected for asthma mortality, the relative contribution of obesity is still meaningful and non-trivial fraction of asthma deaths, particularly among females. So again, we see a consistent pattern. Obesity is not only associated with asthma, but it's contributing to worse outcomes, including death, and disproportionately affecting females. So let's talk about how obesity fits into our asthma phenotype framework. Us asthma doctors love phenotyping. So asthma is an extremely heterogeneous disease, which we subset into a whole bunch of phenotypes that differ by age of onset, inflammatory profile, and what we think is going on with the underlying biology. On the left, we see of what we classically think of as asthma, T2 high, childhood onset, allergic asthma. This group also includes exercise-induced asthma, late onset eosinophilic disease, and asthma exacerbated respiratory disease. These phenotypes are typically driven by type 2 inflammation. They respond well to inhaled corticosteroids, and they respond well to our biologics that target IL-4, IL-5, and IL-13. On the right, however, are the non-T2 phenotypes, which are more common for patients with adult onset disease. And this is where obesity-related asthma consistently emerges. So unlike T2 high disease, obesity-related asthma often presents later in life, maybe non-allergic, frequently has lower eosinophil counts, and tends to respond less robustly to traditional T2 targeted therapies. Importantly, this phenotype aligns with what we've just seen epidemiologically, a strong association in adult women and substantial contribution to asthma morbidity. So to better understand asthma heterogeneity, the Severe Asthma Research Program, or SARP, used unsupervised cluster analysis to identify reproducible clinical phenotypes across large cohorts. What emerged were 5 distinct clusters that differ by age of onset, lung function, atypy, inflammatory patterns, and healthcare utilization. I'd like to highlight cluster 3. This group is characterized by older age of onset, higher BMI, less atypy, some degree of airflow limitation, frequent need for oral corticosteroids despite controller therapy, and low sputum eosinophils. So SARP cluster 3 represents one of the earliest systematic recognitions that obesity may help define a distinct asthma phenotype. In our own group at YCAD, Jose and Jeff and team performed unsupervised clustering after incorporation of serum YKL-40 levels. This yielded 4 distinct YKL-40 clusters, and importantly, these were cross-validated in independent cohorts from SARP and NYU, strengthening their reproducibility. Cluster 4 stands out clearly. They have the highest BMI, predominantly female, later age of asthma onset. Clinically, they report worse symptom control, reflected in the lowest ACT scores, and they demonstrate the highest circulating YKL-40 levels. What I find particularly interesting is the intersection of obesity and YKL-40. So visceral adipose tissue is a known source of YKL-40. So the elevated YKL-40 we see in cluster 4 may, at least in part, reflect adipose-driven production rather than airway inflammation alone. And at the same time, the sputum transcriptomic analysis shows that these patients still demonstrate inflammatory pathway activation. So this raises the possibility that obesity and asthma are interacting biologically, where visceral fat is contributing to the elevated YKL-40, and then that YKL-40 may be amplifying or modifying airway inflammation. So this slide examines genome-wide genetic correlations between obesity-related traits and asthma subtypes. Rather than looking at clinical overlap, this analysis asks the question, do obesity and certain asthma phenotypes share common genetic architecture? So here, the strongest genetic correlations seen in the darkest colors are with late onset asthma and non-atopic asthma, not early onset or classic allergic disease. And we see similar patterns for weight-adjusted BMI, type 2 diabetes, fasting glucose, and fasting insulin. So this suggests that the obesity-asthma connection is not just behavioral or environmental. There appears to be a shared genetic pathway as well. Now, let's shift gears a bit and talk about how these diseases interact mechanistically and how that might affect our diagnostics. So I hope I've convinced you so far that obesity-related asthma is not just more asthma in a heavier body. It's epidemiologically distinct, genetically linked to metabolic traits, and enriched in adult women. The question then becomes, what mechanisms are actually driving this phenotype? So conceptually, obesity influences asthma through multiple interacting pathways. First, there are mechanical effects: reduced lung volumes, increased airway resistance, altered chest wall compliance, and in children, lung dysynapsis. These clearly contribute, but they don't fully explain the differences we observe. Second, comorbidities like sleep-disordered breathing and metabolic syndrome further amplify airway inflammation. Third, obesity creates a state of chronic systemic inflammation. Adipose tissue is an active endocrine organ, producing adipokines like leptin and IL-6, promoting oxidative stress and low-grade inflammation. Fourth, hormonal influences. These include cortisol dysregulation, glucocorticoid resistance, and sex hormones. These may help explain the strong female predominance we've seen. And finally, immune function is altered, with shifts in Th1 and Th2 balance and increased neutrophilic airway inflammation. And what's important to highlight is these pathways don't operate independently. They all interact together and converge on the airway. So I wanted to start with what I think is the most intuitive and sometimes underappreciated piece of pulmonary mechanics. So as you know, obese patients operate at lower lung volumes. This figure illustrates the relationship between BMI and functional residual capacity, or FRC. What you clearly see is that as BMI increases, FRC progressively declines. This reduction in FRC reflects decreased lung volumes driven by chest wall mass loading, reduced diaphragmatic excursion, and increased abdominal pressure. So the consequence is that tidal breathing is occurring at lower lung volumes, closer to closing capacity. So that promotes airway closure, ventilation heterogeneity, and increased airway resistance. So how do these changes affect pulmonary function testing? So mechanistically, what happens is that the FVC falls because patients are operating at lower lung volumes, but FEV1 falls proportionally less. So you get a disproportionate reduction in FVC relative to FEV1. And that can artificially preserve or even elevate your FEV1 to FVC ratio, masking airflow obstruction on spirometry. On the left, what you see is that ERV and FRC are reduced, while TLC and RV are relatively preserved. And that's usually the case until around a BMI of 40. Above that, we can see reductions in those volumes as well. And you see that that FRC is coming close to CC, or the closing capacity. So if obesity can mask obstruction on standard spirometry, what do we do? So one approach is to look at FEV1 over slow vital capacity, or SVC. And here's the physiology behind that. So at low lung volumes, which we just discussed, small airways close early during a forced exhalation. So this means that the measured FVC is actually underestimated because patients can't fully exhale before the airways close. But when you use slow vital capacity instead, you better capture the true vital capacity. And that can reveal obstruction that was hidden on standard spirometry. Clinically, this is not a rare phenomenon. In this large outpatient cohort, about 20% of patients with a preserved FEV1 to FVC ratio had a reduced FEV1 to SVC ratio. And this discordance was more common in obese patients and young patients, those that were under the age of 60. They called this group the target group, which you can see highlighted here in the middle. And importantly, this group of discordant patients had lower mid-expiratory flows, higher airway resistance, and more air trapping. And importantly, they were about 4 times more likely to ultimately be diagnosed with an obstructive lung disease by a pulmonologist. So in patients with obesity, if the symptoms suggest obstructive lung disease, but the spirometry looks normal, consider the FEV1 to SVC ratio. It may unmask clinically meaningful obstruction. The last piece I wanted to touch on the PFTs is the diffusing capacity, specifically the KCO, or what we used to call the DLCO over VA. So KCO reflects gas transfer efficiency per unit of lung volume. So it helps us understand whether abnormalities in DLCO are due to problems with the alveolar capillary membrane or simply reduced lung volume. In obesity, there's a characteristic pattern. Alveolar volume goes down, KCO goes up, so DLCO is often normal or only mildly reduced. So why does this happen? So in obese patients, we're essentially packing the same number of alveolar capillary units into a smaller gas volume, which increases the surface area to volume ratio and makes gas transfer per unit volume look more efficient. Second, obesity is a high cardiac output state, which increases pulmonary capillary blood flow, further elevating KCO. So bringing this back to clinical practice, how should we approach PFTs in patients with obesity? First, interpret results with caution. Both ERS, ATS, and GOLD emphasize that obesity can alter the usual patterns we rely on. So a normal spirometry doesn't necessarily rule out disease. If your clinical suspicion of obstructive lung disease is high enough despite a normal ratio, think about looking at your slow vital capacity. Think about bronchodilator challenges, bronchial provocation testing, or even oscillometry can be helpful, which we don't do here. When interpreting diffusion in patients with obesity, it's important to look at alveolar volume and KCO. Oftentimes, VA will be reduced, and if KCO is normal or elevated, that supports a purely volume-related pattern. But if KCO is low or even normal, that may raise a concern for a true gas exchange problem. And also be cautious about attributing abnormalities to obesity alone. It does affect lung function, but typically only in modest ways. So if something looks significantly abnormal, there may be another process contributing. So beyond what we see on spirometry, obesity also changes how patients experience their asthma. On the left, you can see the physiologic response to methacholine. Both obese and non-obese patients have very similar declines in FEV1 across increasing doses of methacholine. So from a pure lung function standpoint, the degree of bronchoconstriction is essentially the same. But on the right, when you look at symptom perception, patients with obesity report significantly higher dyspnea scores at every level of bronchial provocation. So for the same physiologic change, patients with obesity feel more short of breath. They feel more dyspneic. So this suggests an uncoupling. Patients feel worse even when objective changes are similar. So while obesity clearly alters airway mechanics, it also reshapes the inflammatory landscape of asthma, and that's where the biology becomes more complex. So to begin examining how obesity alters airway inflammation, we can first look at mouse models of allergic airway disease. I promise this is the only slide on mouse models. So in this experiment, lean and obese mice were sensitized and then challenged to induce allergic airway inflammation. On the left, we see total and differential cell counts in BAL fluid at day 24, compared to lean mice, which are the blue and the black. The obese mice, which are the orange and the pinkish salmon color, demonstrate significantly increased total cellular infiltration. On the right, when we examine the lung-draining lymph nodes, obese mice have increased number of not only IL-4 and IL-13 producing cells, the canonical Th2 cytokines, but also interferon gamma and IL-17A and F. This suggests that obesity doesn't simply enhance T2 inflammation, but it may broaden the immune response, promoting a mixed inflammatory phenotype. So what about in humans? So in this data set on the left, this was looking at patients with atopic dermatitis, classic Th2-driven disease. These investigators examined serum protein markers that were induced by IL-17A and IL-13. And what they found was interesting. Markers of cutaneous Th17 inflammation correlated positively with BMI. In contrast, IL-13-induced proteins reflective of Th2 inflammation did not show a significant correlation with BMI. Now, if we look at Airways disease here on the right, we see a parallel pattern. In severe asthma patients within SARP, sputum eosinophil percentage, another hallmark of T2 inflammation, does not increase with BMI and may even decline across higher BMI ranges. So taken together, these data suggest that obesity may shift inflammatory tone away from a pure Th2 dominant response and toward a Th17 associated phenotype. To further understand how obesity alters airway biology, we can look at nitric oxide signaling. So this figure shows the relationship between BMI and FeNO in early versus late onset asthma. In patients with late onset obesity associated asthma, FeNO actually falls as BMI increases despite ongoing disease activity. Obesity appears to alter nitric oxide metabolism through oxidative stress and dysregulated nitric oxide pathways. And as a result, obese asthmatics may become what's called nitric oxide deficient. And this may further contribute to airway dysfunction and inflammation. The key implication is that FeNO becomes a less reliable marker of T2 inflammation in obesity. And this is now reflected in our guidelines. So in the GINA 2025 report, they note that the usual correlation between FeNO and sputum eosinophils is lost in obesity. So building on the idea that our usual biomarkers behave differently in obesity, this slide shows another important manifestation of that disconnect. On the left, you can see peripheral blood eosinophils, and there's essentially no meaningful difference across BMI categories. But when you look at the airway on the right, you can see that sputum IL-5, a key type 2 cytokine, is actually higher in patients with obesity. So maybe airway inflammation is present, even when our traditional biomarkers like blood or sputum eosinophils don't show it. So to better understand this disconnect between circulating eosinophils and airway measurements, this group examined eosinophil trafficking directly. And what they found was that obese individuals with asthma demonstrated significantly greater uptake of circulating eosinophils into the lung compared to lean individuals. So while sputum eosinophil counts may not always be elevated, tissue-level eosinophil accumulation is increased. So this suggests that obesity may enhance eosinophil trafficking, retention, or survival within the airway wall. So perhaps obesity doesn't reduce type 2 inflammation. It may just be compartmentalized in a different way. So taking all this together, we're seeing lower FeNO, normal eosinophils, but elevated IL-5 and tissue eosinophils in this group of patients. So why does this matter clinically? Because the biomarkers we routinely use to identify type 2 inflammation may not perform the same way in obesity. So this is a paper from Nigeria Lugogo at the University of Michigan. And on the left, you can see receiver operating curves assessing how well conventional T2 biomarkers predict sputum eosinophilia across BMI categories. The C index declines progressively from lean to overweight to obese individuals, indicating reduced discriminatory performance in obesity. On the right, when we look at optimal cut points for things like IgE, FeNO, and blood eosinophils, we see that the sensitivity and specificity shifts substantially by BMI group. These T2 biomarkers with their conventional cutoffs are less reliable predictors of airway eosinophilia in obesity. Here, they're proposed different cutoffs for our T2 biomarkers. You see a lower cutoff for FeNO of about 14.5, so we use 25, and eosinophils. Typically, 150 is like the lowest we would say would classify as a T2 signal. In obesity, our biomarkers don't fail because the inflammation isn't there. We just saw that, but they fail because maybe our cutoffs are imperfect. So in other words, absence of evidence is not evidence of absence, which is kind of how we use T2 biomarkers. And if we step back and ask what systemic signals might be linking obesity to altered airway inflammation, the one cytokine that consistently emerges is IL-6. Here we see plasma IL-6 levels across healthy controls and asthma cohorts. IL-6 is significantly elevated in asthma compared to healthy individuals, and levels are even higher in the severe asthma cohorts like SARP. IL-6 is particularly relevant in the context of obesity because adipose tissue, especially visceral fat, is a major source of IL-6. In obesity, IL-6 contributes to chronic low-grade systemic inflammation, and mechanistically, IL-6 has been shown to promote Th17 differentiation and augment neutrophilic inflammation. So IL-6 provides a plausible biologic bridge linking obesity and asthma. There is some evidence to suggest that IL-6 may help define a high-risk, obesity-enriched asthma phenotype. So on the left, we see that elevated IL-6 is far more common in patients with obesity. About 38% of those with a BMI of greater than 30 have high IL-6, compared to only about 8% in the lean group. So IL-6 elevation is clear in obesity. But more importantly, IL-6 levels are associated with important clinical features of asthma, specifically lung function and exacerbations. In both BMI groups, the lean and the obese, individuals with higher IL-6 have lower lung function as measured by FEV1 compared to those with low IL-6. And on the right, high IL-6 in both groups is associated with a greater history of exacerbations, again, across BMI categories. So IL-6 is not merely a marker of adiposity. It may identify a subgroup with worse lung function and higher exacerbation risk, regardless of BMI. And again, IL-6 may capture risk that BMI alone may not. So far we've seen that obesity changes lung mechanics, alters inflammation, and makes our usual biomarkers less reliable. So the next question, does this also change how patients respond to our asthma treatments? I'll let you guess what you think the answer is. So before we talk about treatment response, I just want to ground us in what the guidelines tell us optimal asthma therapy should look like. So here are our GINA guidelines from 2025. And the key thing to note here is that combined ICS formoterol is the foundation for asthma treatment at every stage. At the mild end, there's the anti-inflammatory reliever or AIR approach using low-dose ICS formoterol or ICS-SABA as needed. So even early disease is treated with anti-inflammatory therapy, not just a bronchodilator alone. Then as symptoms worsen, we move to MART or maintenance and reliever therapy with ICS formoterol. So across the spectrum from mild to severe disease, ICS formoterol is the backbone, whether used intermittently, as daily maintenance, or as a combination. But the problem is that this framework assumes that patients will respond predictably to ICS. And in patients with obesity, that assumption starts to break down. So this is a bit of an older study, but it set out to answer the question, do all patients respond to ICS-based therapy the same way? And the answer is no. Patients with obesity are significantly less likely to achieve asthma control with inhaled corticosteroids. Additionally, the effect is graded, meaning the higher the BMI, the lower the likelihood of control, with worse outcomes in severe obesity. And even when we look at ICS plus LABA, which is overall more effective, obese patients still have lower response rates compared to normal weight individuals. So why might this be? Here are two proposed mechanisms. First, the drugs don't get there. And second, even when they do, they don't work as well. So first, the mechanical factors. We've talked about reduced lung volumes, early airway closure, and ventilation heterogeneity. So maybe the ICS isn't getting to where it needs to be in the small airways. There's also the thought that obese patients have a higher volume of distribution, so perhaps the lower effective dose that they're getting is just not working as well. And second, there's immunologic factors. So we've talked about how obesity can shift patients towards non-T2 or neutrophilic inflammatory phenotype, which is less responsive to things like ICS. And patients with obesity have also been found to have altered glucocorticoid signaling, and that may mean that the steroids are less effective at turning inflammation off at the cellular level. So taken together, both reduced drug delivery and reduced immunologic responsiveness lead to a blunted response to ICS in this population. So building on that idea of reduced responsiveness to ICS, this next study takes it a step further by asking whether different controller therapies behave differently across BMI. And what they found is that as BMI increases, the response to inhaled corticosteroids progressively declines. So you see on the left that in normal weight patients, inhaled corticosteroids, here beclomethasone, have the strongest effect on asthma control. But as BMI increases, the benefit diminishes. And on the right, you see this more clearly. There's a progressive decline in response to ICS as BMI increases. In contrast, the response to montelukast, a leukotriene receptor antagonist, remains relatively stable across BMI categories. So as a result, in patients with obesity, the difference in effectiveness between ICS and montelukast essentially disappears. And this raises an important mechanistic possibility. Maybe obesity-associated asthma is less corticosteroid responsive and more leukotriene driven, which could have implications for how we tailor therapy in our patients. So if response to inhaled corticosteroids is blunted in obesity, what about biologics? So this is real-world data from the UK Severe Asthma Registry. And what we're seeing here is that across BMI categories, patients treated with biologics, so the shown in green, consistently have greater reductions in exacerbations than those not treated. So that's the red ones. So biologics clearly work across the BMI spectrum. But there are two important caveats. First, in the severely obese group, the exacerbation benefit is less pronounced. Second, these patients start at a higher baseline, more symptoms, more exacerbations. So even after treatment, a larger proportion remain uncontrolled. So biologics are effective, but they may not fully overcome the underlying increased disease burden associated with obesity. And we'll take a look at that a little bit more closely. So this is data looking at outcomes with anti-IgE therapy, so Xolair. In the top panel, obesity, particularly class 1, is associated with higher odds of persistent symptoms reflected by ongoing SABA use. And on the bottom, both class 1 and class 2 obesity are associated with significantly higher odds of exacerbations. They found a roughly threefold increase in exacerbation risk despite treatment. Practically speaking, Xolair dosing caps at about 150 kilos, so some of our highest BMI patients aren't getting this drug. And here I'm summarizing some of how the other biologics perform specifically in patients in obesity. And the red arrows highlight where we have obesity-specific evidence, which is pretty limited. So starting with mepolizumab, we see consistent reductions in exacerbations, some signal for improved lung function, but outcomes appear better in patients with lower BMI. For benralizumab, there's a clearer signal that efficacy may be attenuated in patients with a BMI over 35, particularly for symptom control and exacerbation reduction. In contrast, dupilumab appears to be pretty consistent across BMI categories, at least with the data that we have. Similarly with reslizumab. And basically the key takeaway here is that not all biologics behave the same in obesity, and with more data that may actually help us guide selection in the future. Now, in contrast to what we saw with some of the other biologics, anti-TSLP therapy with tezepelumab appears remarkably consistent across BMI categories. This is pooled analysis of the Pathway and Navigator, the big Tezspire trials, and showed a similar reduction in exacerbations, whether patients were normal weight, overweight, or obese. So unlike the IL-5 or the IgE-directed therapies, where we start to see that attenuation of response at a higher BMI, Tezspire seems to be largely BMI independent. I think this probably reflects the upstream mechanism targeting TSLP at the level of the airway epithelium as an alarmin rather than the downstream inflammatory pathways that may be more altered in patients with obesity. So clinically, I think this suggests that anti-TSLP therapy may be a particularly attractive option in patients with obesity where other biologics may be less reliable. All right, so up until this point, we talked about how obesity alters asthma biology, physiology, and treatment response. So is obesity just a modifier of disease, or is it a treatable trait? So if obesity is a treatable trait, what happens with weight loss? So on the left, we see patients who achieved greater than 10% weight loss, and they have a marked improvement in symptoms with significant reduction in their ACQ scores. In contrast, those with 10% or less weight loss had much more variable and overall non-significant changes. And we see that same pattern with lung function on the right. Meaningful improvements in FVC are really driven by that greater than 10% weight loss threshold. So the key takeaway here is that 10% more of weight loss may improve symptoms and lung function. And I often have patients ask me about nutrition, dietary recommendations to improve their asthma. But when it comes to nutrition, the reality is that the data is really poor quality, as it is across many things with nutrition. But that said, a few signals stand out. Obviously, weight loss, which we just discussed, that's actually included in our GINA guidelines now. Bariatric surgery, which I'll talk about in a second, shows consistent improvements, but this is observational data. But beyond that, really, the picture is not very clear. Maybe there's some associations with Mediterranean diet, increased fiber intake, omega-3s, vitamin D, but studies have been inconsistent and don't really show a clear overall benefit for patients with asthma. So while diet matters, the most evidence-based nutritional thing we can do is weight reduction itself. So let's take a look at bariatric surgery. So bariatric surgery provides some of the strongest signal in improving asthma outcomes. So across studies, over half of patients, 54%, are able to discontinue all asthma medications, which is like remarkable. We also see about a 60% reduction in ED visits and hospitalizations. And what's also striking is that these benefits appear durable out to 8 years, even with some degree of weight regain. In terms of who benefits most, it does tend to be patients with late onset non-atopic asthma, especially those without significant metabolic syndrome. And from a procedural standpoint, sleeve gastrectomy and gastric bypass seem to have comparable outcomes. So overall, this is some of the strongest evidence that treating obesity can fundamentally change the trajectory of asthma, not just incrementally improve it. And just to emphasize, asthma is formally classified as a severe obesity-related comorbidity, so alongside things like diabetes and sleep apnea, which means it can be an indication for bariatric surgery at a lower BMI level. And if we think in terms of treatable traits, OSA is probably the most important comorbidity to address in obesity-associated asthma. In this prospective study, after just 6 months of CPAP, we see fewer uncontrolled patients, fewer exacerbations, and improvements in both symptoms and markers of inflammation. And this is where things are evolving and I think getting exciting. Now, tirzepatide or Zepbound is FDA approved for the treatment of moderate to severe sleep apnea and obesity. So we can think about these therapies not just as weight loss drugs, but also as potential targets to improve asthma outcomes in the same time. So beyond weight loss, GLPs may have direct immunometabolic effects in asthma. They appear to downregulate type 2 inflammation with reductions in IL-4, IL-5, and IL-13, leading to less eosinophilic activity and IgE signaling. At the same time, they may reduce upstream epithelial cytokines, TSLP, IL-33, and there's also signal for effects beyond T2 inflammation, including reduced neutrophilic inflammation and platelet activation. So these drugs maybe are not just treating the obesity, they may also be modulating the inflammatory environment in the airway itself. And I think this gives a rationale for why targeting metabolism might translate into better asthma outcomes. So clinically, we're starting to see a consistent signal across multiple real-world studies, although current data is limited to just patients with asthma and and diabetes. In this group, GLPs are associated with fewer exacerbations, reduced oral corticosteroid use, and improved asthma control. And importantly, in some analyses, the GLP-1s outperform other diabetes and even weight loss medications, suggesting that it may not be weight loss alone. Again, these are observational, not definitive, but the consistency is compelling. We'll skip this one. And one of the most compelling findings comes from a large real-world study of patients with asthma and type 2 diabetes. And this group found that other diabetes medication classes were associated with significantly higher asthma exacerbation rates compared to patients with asthma and diabetes that are treated with the GLP-1. And importantly, these effects persisted even after adjusting for glycemic control and other confounders. And even more interesting, when investigators stratified by weight loss, exacerbation reduction occurred even among patients who didn't lose that much weight. They defined that as less than 3 kilos. So I think that's really exciting. And before closing this treatment section, I think it's important to recognize how dramatically the therapeutic landscape has changed for both asthma and obesity in recent years. On the obesity side, GLP-1 receptor agonists, dual GLP-1s, GIPs, are increasingly effective tools to treat obesity. And I also think it's important to keep in mind the cost of these things. Biologics, as we know, are incredibly expensive, and so are weight loss drugs, but maybe a little bit less so. So effective obesity treatment may improve asthma outcomes while potentially reducing reliance on these high-cost biologics. So let's bring it back to our case. So when I met her in February 2024, we added tirzepatide to her regimen. In the past 2 years, she has lost 90 pounds. Her BMI is almost out of the obese range. It was 30.8. Her A1C, it's going backwards, is now normal. Her ACT score has improved from 5 to 22. 25 is perfect. And I just saw her last week. She hasn't had any recent exacerbations. She's tapered off prednisone. She's still on Tezspire and tirzepatide. She takes no inhalers. She's off opioids. She's off Lasix, no more insulin. She's back to work, and she's taking care of her 3-year-old. So just to summarize a practical approach, how do we manage these patients with obesity and asthma? Confirm and characterize the physiology. We talked about PFTs. Interpret biomarkers cautiously. Optimize their standard therapies, knowing that they may not work as well. Reassess early. Escalate thoughtfully. Treat their comorbidities, especially sleep apnea. And address obesity as a treatable trait in asthma. Think about the weight loss drugs. Maybe this is a multidisciplinary approach that would be helpful. So in summary, obesity is highly prevalent, doesn't simply worsen asthma, it contributes to a distinct phenotype of disease. Mechanisms include mechanical effects, alterations in immune function, and inflammation. Traditional T2-based diagnostics and therapeutics are imperfect in this group, and metabolic therapies and interventions may become a really important piece of how we treat our patients with obesity and asthma. Thank you for listening.
Thank you so much for the amazing review. Any questions?
Thank you for that excellent talk. And it's really amazing what you did with that patient. That ACT score in the end was just phenomenal. So I have two questions. So the first is that I know you said there's a differential response between ICS in obese versus non-obese patients, and also with biologic use. But in general, do you consider biologics earlier in obese patients just because you are thinking that they're less likely to respond well to ICS therapy alone? That's one question. And the second question was, when you talked about how asthma control is different in obese versus non-obese patients, I'm wondering what metric you're using. Is it the ACT score itself? Because so many components of that are subjective. And I know obesity is also associated with deconditioning and can affect what patients report on their ACT score. So is that really an improvement in asthma control or just a subjective assessment of asthma control?
Thank you. Good questions. So the first question was, am I more quick to go to biologics in patients with asthma and obesity because they may be less likely to respond to things like ICS? And the answer is probably. I will say I am pretty aggressive about treating the comorbidities because I do think that the obesity-related comorbidities have such a big impact on asthma. So I'll say I do start there, but I would say not even just in obese patients, but in all patients. If they're uncontrolled despite inhaled therapy, I think we're all pretty quick to go to biologics these days because they work so well, they're so well tolerated, and we have such good outcomes. And then the second question was, how are we measuring obesity as something that worsens asthma control, and how do we capture that? So I agree. The asthma control test, ACQ scores, mini AQLQ, they're all subjective. So a piece of it is definitely subjective. So we're looking at those scores, but we're also looking at things like exacerbations, need for prednisone, need to go to the hospital. And those things, those objective things, are also worse in this group. So I think it's a combination, but it's definitely subjective and objective worsening.
Thank you so much.
Thank you, Shannon. This was awesome. Really, really great. I've actually heard a few obesity and asthma talks, and yours is by far the best.
Thank you.
I wanted to ask what you thought. For the GLP-1s and other comorbidities like OSA, for example, it can eliminate your need for CPAP completely.
Yep.
And for diabetes, it could eliminate your need for other hypoglycemics. But do you see a world in which, from what you understand about the physiology, that a GLP-1 alone with the absence of other asthma treatments is something, or is this just one of the tools that is helpful, but not something that's going to preclude you from needing a biologic or a inhaler?
I think that's a good question. So I think the nuance is that sometimes patients are attributing symptoms to asthma that maybe isn't asthma. So I think in that group where their predominant symptoms really are things related to their obesity, that perhaps weight loss alone may get them controlled. But I think that if they do have symptomatic airways disease, I don't think a GLP-1 alone is or a weight loss drug is gonna fix it. I think that biologically speaking, it makes more sense that they're still gonna need the biologic.
Shannon, thanks for your great talk. I have two questions. One relates sort of as a follow-up to that, which is did you come across any data in the studies about bariatric surgery and improvements in asthma control? Are there any studies of airway biopsies in people who've had bariatric surgery to know if any of this has to do with actual alterations in structural changes in around the airway versus just the mechanical effects of weight loss itself? And a second question is, clinically, as we all know, two hugely common mimickers of asthma in the obese population would be variable dynamic extrathoracic upper airway obstruction, and also underlying tracheobronchomalacia, and including in people who've had recurrent so-called exacerbations where they're put on steroids over and over again. So it seems to me that in a lot of the asthma obesity studies, those factors are not either systematically evaluated or excluded. And I'm just wondering if you could comment on those two questions.
Sure. So to answer the second question first, I actually had a slide about this that I wound up cutting out. I had a lot of slides I wound up cutting out. But just looking at airway collapsibility in obese patients. Can you see it? Okay. And basically what we do see is what you said. So we see enhanced collapsibility of airways in patients that are obese, regardless of the presence of airway disease. And this can be a huge mimicker. But I think it's something that's hard to identify, but I think it's something that we need to know is a feature of obesity, regardless of airways. So if our asthma therapies or COPD therapies are not working for these patients, I think then it's worth a look, getting inspiratory, expiratory films. Is TBM really the driver here? So that's one piece. And then your first question was looking at the bariatric surgery data. I did not come across anything looking at lung biopsies, but I agree that that would be something really interesting to see, what's actually happening in the airways. Why is this such a good treatment? And how much of it is the weight loss and how much is it treating the disease? Yeah.
Excellent. Thank you so much, Shannon. And thank you for joining us today.